All right, thanks everybody for showing up. We've got a few people who are going to be joining us still, but welcome to all of you to the Medicaid Insights Colloquium, also known as the MIC. I'm glad that you're all tuning in today. My name is John McConnell, and I'm a professor at Oregon Health and Science University and director of the Center for Health Systems Effectiveness. And as usual, I'm going to start by going over a few quick notes for our time together today. This session will run for about an hour, including 40 minutes of presentation, followed by 20 minutes of Q&A. Because there are so many of you joining us today, we're going to ask that you refrain from using the raise hand function. And if you have a question, and you probably will have a lot of questions during the presentation, you can submit it at any time by clicking on the Q&A button at the bottom of your Zoom window. And we'll get to as many questions as we can after the presentation. I want to take a quick moment to recognize the rest of the MIC Planning Committee for their continued work in planning these events. Sarah Gordon is an assistant professor at the Boston University School of Public Health and co-director of the BU Medicaid Policy Lab. Jamila Michener is an associate professor of government and public policy at Cornell University. She is the co-director of the Cornell Center for Health Equity and co-director of the Politics of Race, Immigration, Class, and Ethnicity Initiative and board chair of the Cornell Prison Education Program at Cornell University. And Will Shapiro is an assistant professor in the Division of Health Policy and Economics of the Department of Population Health Sciences at the Joan and Sanford Weill Medical College of Cornell University. So now I have the pleasure of introducing Dr. Jenny Kenney. Jenny is an Institute Fellow in Health Policy at the Urban Institute. She is a nationally known expert on Medicaid, having played a lead role in several Medicaid evaluations and conducting state-level evaluations of the implementation of managed care and other service delivery reform initiatives and policy changes. Currently, she's working in the areas of reproductive health access in Medicaid and Medicaid policies aimed at improving outcomes in the postpartum period, and she's also studying the unwinding of continuous coverage in Medicaid. Today, she's going to share her thoughts on the implications of the incoming administration on Medicaid and Medicaid research. I am really excited to get her perspectives today because of her position at Urban and proximity to Washington, D.C. In my discussions with her, I found that she's got a little bit of a closer read on some of what's happening at the federal level, and she's the perfect person to have on for Mike at this time of the election cycle and the new administration coming in. I do want to share that, unfortunately, Jenny is recovering with COVID. She's in week 2, so she's not feeling her best, but she still agreed to come give this presentation, so really grateful there. I'm really glad to have her talk. I really love reading Jenny's papers, but I also like talking to her, and she is unable to contain her sense of urgency or excitement or concern when she's talking about topics that she thinks are really important, and that adds some color to her commentary, and I think you'll be in for a treat in listening to her. So delighted to welcome you, Dr. Kenney, and please want to have everybody here join me in giving a warm welcome to Jenny and her talk today.
Thank you, John. I'm going to just try to make sure I get my slides up here properly. Let's see. I practiced this. I can do it. I did it. Well, I'm going to just start by thanking John for such a kind introduction, and by thanking the MIC team for organizing this series and making all the recordings available. The past presentations from the last several years include a mother lode of important insights and knowledge, and I can't recommend them highly enough as a go-to resource for Medicaid researchers and others in the Medicaid policy ecosystem. Today's talk is going to be a little bit different from many of the past ones. I won't be talking about a particular research project or specific policy area within Medicaid. Instead, I'm going to highlight what might be coming down the pike with respect to Medicaid policy in light of the Republican trifecta at the federal level that resulted from last month's election. The headline is that Medicaid researchers should be ready for major battles around Medicaid in the next year and possibly the next 4 years and beyond, concerning whom Medicaid should serve, what should be required of enrollees, how much federal support it should get, how much latitude states should have in designing their programs, and what types of oversight and accountability are needed and appropriate. I'll also share some thoughts on Medicaid research that I think could be particularly helpful if there are proposals to make dramatic funding cuts or other structural changes to Medicaid, and if such changes are enacted, and highlight a few research areas in Medicaid that I think warrant more attention independent of the election outcome. In putting this talk together, I drew on research papers and analyses, including from many on this call. Since the election, I've also had informal conversations with people across the country who sit in different places in the Medicaid policy and research landscape. My views have also been shaped by collaborators here at Urban and beyond, with whom I've had the honor of working over these last 30 plus years, as well as those in the Medicaid advocacy community, those in healthcare plans and providers that serve Medicaid, and importantly by Medicaid enrollees themselves, who have historically had very little input into Medicaid policies and practices that affect their healthcare, or into the research that is done on the program. I've been deeply fortunate these last 4.5 years to work with a standing community advisory board that informs and guides much of Urban's research on Medicaid, and have witnessed how this engagement affects the research questions we pose, the interpretation we give to our findings, and their implication for policy and practice, and how we frame and disseminate our research. So all to say, I owe thanks to many different people, and it's likely that any valuable insights I share today are not original to me, but come from someone else in the Medicaid ecosystem. Before I dive in, excuse me, I wanted to say something about why I think it's so important that we bring our best minds to this research area. And here's John, where I'll proselytize a little bit. I'm guessing that many who are participating today or watching the replay are already on board with the proposition that the people who are served by the Medicaid program, people with disabilities, poor and low-income children, and elderly and non-elderly adults, do not have political power commensurate with their numbers, and often have lacked the ability to command the resources and the influence needed to drive policy change that would help them better meet their needs. And despite having greater healthcare needs than other groups on average, they are hit with the double whammy of often lacking access to affordable private sources of insurance or care, and to other financial resources on which they can draw to finance their healthcare and address their and their children's basic needs, healthcare included. Moreover, low-income people face higher levels of stress day to day. And although we know that public benefits like Medicaid can help people, they can also bring with them administrative challenges that are time-intensive, anxiety-provoking, and humiliating, I think, sometimes, and that make it even more difficult for them to meet their basic needs. Consequently, I think it's really important that we identify policies that would tackle the pressing problems that low-income and disabled people are facing in getting access to high-quality healthcare, and that hamper state Medicaid programs from achieving the best results with the available resources. Given that things may move very quickly on the legislative front in 2025, the time to anticipate what might be coming in Medicaid is now. It's important that Medicaid researchers be ready to provide information on consequences of potential changes so that federal lawmakers can be held accountable for any votes they make. Researchers also have an important role to play in informing executive actions on Medicaid at both the federal and state level. And to the extent that major changes are made in Medicaid, it will be important that researchers are ready to assess how these changes are affecting people, communities, providers, how different policy choices are playing out across states, and to provide information that's relevant for Medicaid stakeholders and decision makers at both the federal and state level. I see this coming year as another round in the ongoing debate about what role Medicaid should play in our healthcare system, and also about who is quote unquote deserving of publicly subsidized healthcare and on what basis. But certainly not the final round by any means. So building the evidence base remains crucial for future decisions and debates. In terms of today's talk, I'm going to identify excuse me, what I see as some potentially important Medicaid policy changes that could be considered by the new Congress and administration. It's going to provide some background on Medicaid's role in the healthcare system as a grounding for thinking about changes to the program, and touch on some actions from the first Trump administration that could foreshadow executive branch actions this time round. And also flag some Biden-era initiatives in Medicaid that could be at risk. I'll close by identifying some research areas to prioritize in response to likely policy proposals and potential changes that may be coming in Medicaid, and flag some areas that I think deserve more attention than they have received to date, independent of any changes to the program. Okay, so I think our best indication of what may be proposed in terms of federal legislation comes from blueprints that a number of prominent conservative think tanks and other Republican-affiliated groups have released that would substantially reduce Medicaid, federal funding for Medicaid, and Medicaid eligibility, potentially. These Medicaid proposals include reductions in the federal medical assistance percentage, or FMAP as it's commonly known, which reflects the share of Medicaid spending that the federal government covers. Could include the imposition of block grants. These proposals have included the imposition of block grants, the establishment of per capita spending caps in Medicaid, and allowing or even requiring states to establish work requirements in their programs, among other things. Specific policies include eliminating the enhanced FMAP for Medicaid expansion under the Affordable Care Act. Currently, the federal government covers 90% of those costs, service costs, and eliminating another set of proposals would eliminate the FMAP floor, which is at 50%. That would lower federal funding for all areas of Medicaid spending, not just the expansion population, but including on children, the elderly, the disabled, in as many as 10 states and the District of Columbia. Capping federal Medicaid spending through federal block grants or per capita caps. Now, dropping the federal matching rate on the expansion population would lower the federal matching funds that states would have to cover this population from 90 to somewhere between 50 and 77% under current rules. That would affect 40 states in the District of Columbia that have implemented the Medicaid expansion under the ACA. According to a recent KFF analysis, these states include 24 states that voted for Donald Trump in the last election, or that have a Republican governor. However, I think it's worth noting that several of those states advanced Medicaid expansion through a ballot initiative, and thus may lack support for it from the governor or the state legislature. Note that 9 states have so-called triggers in place, such that when the federal matching rate for the expansion population falls below 90%, the expansion could immediately be revoked. And even for states that don't have such provisions, there's still a large risk that states will pull back on expansion coverage, given how large the funding burden would be on states associated with trying to make up for the lost federal dollars they would experience with a lower matching rate. especially if they're facing tough budget situations in the coming budget cycles. The expansion population numbers over 15 million nationwide, so rolling it back would have a substantial impact on uninsurance, particularly among poor and near poor adults. It's worth noting that the expansion is not the only thing at risk if federal funding drops for that group, as that could make it more difficult for states to maintain eligibility and benefits for other groups. Some of these policy proposals were included in ACA replacement bills that were voted on during 2017. And several have been kicking around a lot longer than that. In fact, proposals to impose block grants and per capita caps in Medicaid go back decades. And CBO has routinely scored these proposals as options to reduce the federal deficit. At this point, we do not know which specific legislative proposals will be made, when they will be released, whether they'll be paired with efforts to extend and possibly expand upon the 2017 tax cuts that are set to expire in the coming year. Some estimates put the cost of extending the 2017 tax cuts at $4 trillion over 10 years, which could require cuts elsewhere in the budget to finance. In addition to major changes in the financing structure of Medicaid, federal legislation could include other changes, such as allowing or requiring work requirements for Medicaid enrollees, imposing more frequent eligibility redeterminations that make it harder for enrollees to retain coverage, or lowering the expansion eligibility threshold from 138% to 100% of the federal poverty level. I should note, of course, that other proposals are certainly possible. Just focusing on some of the big picture ones, but we could see efforts to limit or eliminate federal funding to Medicaid providers who offer abortion services or provide gender affirming care, or changes to the interpretation of EMTALA for hospitals providing emergency care in states with abortion bans, for example. We could also see federal legislation that includes changes like what was proposed in Idaho this past year for its expansion population. Now, Idaho was a state that expanded resulting from a ballot initiative. The Idaho proposal in the last session would have included work requirements in the expansion, lifetime limits on Medicaid enrollment, and a cap on enrollment. We might also see more ballot initiatives like the one that passed this year in South Dakota that would allow work requirements for the expansion population if the federal government permits them. And again, I'll note that South Dakota was a state where the expansion happened as a result of a ballot initiative. So with major changes to Medicaid potentially on the horizon, I think it's important to start from the point of considering who the Medicaid program currently serves, what groups of people and states stand to be affected by different policy changes. We all know Medicaid was created back in 1965, even if we don't remember that. But its purpose was to finance healthcare services, including nursing home care, for designated poor and disabled groups, so categorically eligible groups. It has since expanded to cover additional groups like low-income pregnant people and children, including CHIP, adults up to 138% of the federal poverty level, under the ACA, postpartum people, and to cover home and community-based services. Medicaid also covers Medicare premiums and wraparound coverage for low-income Medicare beneficiaries. Well, Medicaid is jointly financed by federal and state funds, and states must conform to federal standards with respect to eligibility and benefits, but can adopt more generous policies and have latitude over service delivery and payment. They also have flexibility to apply for Medicaid waivers as demonstration projects. Like Medicare, Medicaid was established as an entitlement program, which means that anyone who qualifies is entitled to services. And it also means that it comes with a guarantee of federal funding. This is one reason that introducing block grants or per capita caps would be so impactful. They would basically take away the entitlement. Among other things, Medicaid is the single largest payer for prenatal care, for deliveries, nursing home care, long-term care services and supports, mental health, substance use disorder services, HIV services, and I know the list goes on. Children rely on Medicaid and CHIP, Medicaid CHIP for coverage at much higher rates than adults. And 85% of all poor children and 58% of all poor adults rely on Medicaid for coverage. While white children and adults constitute the single largest racial ethnic group covered in Medicaid, Medicaid provides coverage to over half of all Black, Hispanic, Native American children, which means that changes to Medicaid would have outsized effects on children in these groups. The old saw that if you've seen one Medicaid program, you've seen one Medicaid program is certainly true when it comes to who's eligible for Medicaid in each state. Focusing on the expansion population, which has been the target of so many recent policy proposals. As I indicated earlier, all but 10 states have expanded Medicaid under the ACA up to 138% of the federal poverty level. In the holdout states, there's no Medicaid coverage available for non-disabled, non-pregnant people without dependent children. And among those with dependent children under the age of or 18 and under, the median eligibility threshold is just 34% of the federal poverty level. So poor individuals with incomes above that can't qualify for Medicaid. Among the 9 states that waited to expand Medicaid coverage until the last 5 years, 7 were ones where the expansion occurred as a result of a successful ballot initiative. These states are identified in italics at the top, in the top row. Recent data show that kids, and as you can see, sorry, there's also notable variation across states in eligibility for other groups as well. Kids constitute the single largest enrollee group in Medicaid. While the exact percent differs from year to year, the kids have constituted that single largest group over time. And while disabled and elderly adults make up less than a quarter of all enrollees, they account for over half of all Medicaid spending. And with the aging of the baby boom, healthcare needs in this group are expected to keep increasing over time. Okay, so these spending patterns across are driven in part by very different per capita spending for different enrollment groups. As one would guess, spending per capita is many times higher for seniors and the disabled than for other groups, while Medicaid programs spend much less per capita on kids. Per capita spending levels vary substantially across states for a given enrollee group as well. This figure, also based on data from KFF, shows the highs and lows and mean spending level per capita across states for each of these different enrollee groups. While there's strong overlap in the states with high per capita spending for the disabled and for seniors, different states tend to be at the top in terms of per capita spending for kids and expansion adults than for seniors and the disabled. I'd note that we don't really understand much about these differences and that this is a place that I think would benefit from more research that provides evidence about both the drivers and the consequences for health and well-being of these differences. But it also reinforces that any fundamental change like block grants or per capita caps would be imposed against a backdrop of highly variable programs in terms of eligibility and how much states are spending per capita on each group, which in turn would lock in profound differences in state programs and potentially lead to substantial redistributions of federal funding across states. With Medicaid's focus on addressing healthcare for poor and disabled individuals, the program disproportionately serves those who have mental health or substance use issues. I would absolutely recommend Julie Donahue's talk on this issue. Fully 4 in 10 non-elderly adults covered by Medicaid self-report as having mental illness or a substance use disorder, and 11% self-report as having both. Thus, we would expect unmet needs for mental health and substance use treatment to rise if Medicaid coverage is cut back for adults. Capitated managed care payments constitute over half of all spending on Medicaid, and all but a handful of states provide Medicaid services for non-elderly adults and kids through capitated managed care plans. The composition of spending varies across groups, with over a third of spending on the elderly and the disabled beneficiaries, for example, going to long-term care services. And Medicaid is currently paying for an estimated 61% of all spending on long-term care, with the majority now going to home and community-based settings. So data available on federal Medicaid spending from 2022 show it at nearly $600 billion, constituting 9.2% of federal spending. I'll note that 2022 was somewhat of an atypical year because of the public health emergency, which raised Medicaid enrollment levels and provided states with an enhanced federal match. So federal spending was likely higher in that year than it would be in a normal year. Okay, so altogether, Medicare and Medicaid and Social Security account for between 30 and 40% of the federal budget. But you might recall that promises were made during the campaign by the incoming president to exclude Medicare and Social Security from such cuts, but not Medicaid. If we look to the first Trump administration for indications of what's to come, we could see pieces of what was proposed in 2017 with respect to ACA repeal and replace, which included substantial cuts in federal funding for Medicaid, as well as other new restrictions like work requirements. But unlike the first Trump campaign, ACA repeal was not a part of the Trump campaign's promises this time around. But as I showed earlier, a number of recent Republican proposals have included major federal cuts to Medicaid, and several House Republicans have voiced support for cuts in recent weeks. Trump did campaign on the promise of lowering taxes, and tax cuts are seen as a major priority for the new administration. Legislation passed during the Biden administration included the option of extending postpartum coverage, mandating 1 year continuous coverage for children in Medicaid and CHIP, expansion of Medicaid coverage of vaccinations, and cost sharing associated with vaccinations. It's not clear whether there'll be efforts to roll back any of the Biden-era legislative accomplishments. On the one hand, at least one state has contested the 1 year continuous eligibility policy for kids. So that's just one state of which I'm aware. And it's worth noting that almost all states have expanded Medicaid during the postpartum period. So that policy is being implemented in all but a handful of states. The focus of Medicaid waivers was quite different under Presidents Trump and Biden. The Trump administration approved 1115 waivers in Medicaid for longer periods of time than had historically been the case, and also required less reporting. Following guidance that was issued in January of 2018, the Trump administration approved so-called work and community engagement requirements for 13 states. Waivers were also approved in Texas and Florida, providing uncompensated care funds for hospitals in lieu of Medicaid expansion, and in Tennessee with an aggregate federal funding cap. In 2020, the Trump administration also released the Healthy Adult Opportunity Demonstration with aggregate or per capita caps that allowed for changes in eligibility, benefits, cost sharing, et cetera, with fewer public comment opportunities. No demonstrations were implemented under this authority. The Oklahoma applied for, but subsequently withdrew its proposal. Its proposal would have been a block grant with work requirements and premiums and other changes, such as the elimination of retroactive eligibility. Oklahoma withdrew its proposal after the successful ballot initiative for Medicaid expansion passed. Under Biden, the Trump era priorities related to premiums, the 10-year option for waivers, and the aggregate cap were not continued. And as folks who heard Vicky Joaquino's talk from earlier in the series in October know, the Biden administration issued guidance in 2023 on reentry transitions for incarcerated individuals. As of November 2024, the administration had approved Medicaid waivers in 11 states, and I think there were pending waivers in another 15 states. It's worth noting that these waivers have been approved and proposed in large numbers of both red and blue states. But that they also hinge on the Medicaid extension being in place. They really are built on the Medicaid expansion being there to provide eligibility for folks who are reentering the community. Given the mix of states that have embraced these waivers, should the Medicaid expansion stay in place, it would seem likely that the reentry waivers may have a strong chance of continuing. The Biden administration also issued guidance and new demonstration authority on health-related social needs, and as of November 2024, had approved waivers that would use Medicaid funding to cover housing and nutrition supports, as well as other services for targeted populations in 10 states. I think there's somewhat more concern about whether these waivers will be supported by the new administration. The Biden administration also approved waivers for multi-year continuous coverage. 3 states started implementing in 2023 and early 2024. I think today we just learned that a 5th state, an additional 5th state, had received approval to begin implementing this type of waiver. No idea what kind of support or opposition there might be to this in the new administration. Well, given all the focus on immigration in the campaign, and in the early pronouncements of Trump officials from the new administration, we might expect to see, I think we would expect to see a reinstatement of the public charge rule from the Trump era. And we might see additional restrictions placed on federal Medicaid funding for non-citizens. I'm expecting that we'll see less funding for enrollment outreach and assistance, and more emphasis on keeping ineligible people from being covered, like emphasizing error rates, which could undo efforts to increase reliance on ex parte renewals that were aimed at helping eligible people stay covered. I wanted to flag one thing that the first Trump administration did support, and that was the release of TMSIS data. I can talk more about that, but we've seen that continue, but I view that as something that might be hopeful for Medicaid researchers to think about. I've also flagged different rules that the Biden administration released that may be rescinded or revised by the coming administration. Okay, so to research, I think we should be prioritizing. For starters, and I don't think this is going to seem very interesting from a research perspective, but I think there's really going to be a need in the coming months for research products that describe the Medicaid program in each state, who's enrolled, where the dollars are going, what services are being covered, and by what providers, overall and by age group, disability status, separately for the elderly, disabled, kids, non-elderly adults, by income, race, ethnicity, geographic location, rural, urban status, healthcare needs, work status, etc. Likewise, and on the same time horizon, it will be really important to convey what we know about Medicaid's impacts. I know many of us are well familiar with this literature, but I assure you that's not a safe assumption when dealing with lawmakers and their staffs. I think it's important to think broadly here. What have been the impacts on health insurance coverage, receipt of preventive, other types of healthcare, financial burdens, medical debt, unmet needs for care, on health, mortality, on other sectors, and on different types of providers like FQHCs and hospitals, and providers of mental health and substance use services? What have been the fiscal and economic impacts of Medicaid at the state level and of Medicaid expansion in different states? What do we know about the short and long-term impacts of Medicaid expansions for kids and adults? Without Medicaid, what are the prospects that people have alternative sources of coverage or other funding sources to cover their healthcare needs? To what extent do low-wage workers in your state have access to employer-sponsored insurance? And if they do, what would it cost relative to their incomes? And what protection would it offer toward out-of-pocket cost sharing? Are other funding sources available to cover long-term care services for the elderly and the disabled individuals who use them now? If not, what are the prospects that that population could afford such care out of pocket or find other ways of getting their needs met? And if major changes like cuts in the federal match rate or work requirements are being debated in Medicaid next year, information will be needed about potential impacts for each state to help lawmakers and others understand what's at stake. Any federal legislation that gets voted on will be scored by CBO, but CBO scores focus on health insurance coverage and on federal Medicaid and other health spending, thus missing impacts on families' financial burdens and on other sectors like special education or criminal justice. And CBO scores do not provide state-specific estimates, so research will be needed that speaks to the potential impacts for each state and for different sub-state breakdowns and population groups as well. It will be important to share research findings with legislative decision makers and officials in governor's offices, as well as with enrollees and other important Medicaid stakeholders. Accessible translations of findings from long research reports or peer-reviewed publications will be needed that reflect the concerns and issues that are relevant to a particular audience. And where possible, important to put a human face on the numbers to bring issues to life with real-world examples. And if major changes are made in Medicaid, like work requirements, or decreases in the federal matching rate, or block grants, research will absolutely be needed that documents the impacts of those changes in real time as much as possible, nationally and at the state level. Oops. I can't go back without messing up. So I'm just going to say, we're going to need analyses that assess impacts on people, communities, and providers. And we're going to want to look to the literature on Medicaid expansion and the unwinding as examples of the types of research that I think would be useful and doable, and provide more, that would provide more timely information over the next couple years. Okay, so as promised, I wanted to touch on some other Medicaid research questions that are on my mind. Before I do that, even without major legislative changes in Medicaid, there will be opportunities for researchers to bring, actually, I'm going to try to go back to that slide. Okay, even without major legislative changes in Medicaid, there will be opportunities for researchers to bring evidence to bear on state and federal actions through comments and other analyses related to proposed rules or to the rescinding of rules, say the access or enrollment rules that were released this past spring. And researchers should consider contributing to amicus briefs in response to litigation. While judges do not always pay attention to evidence when making decisions, there's certainly compelling examples where research findings have affected prior rulings. Okay, so I wanted to close with some thoughts on other Medicaid research areas to consider. This is not at all a comprehensive list or systematic, but it might be a place to get a conversation going. First, I think we really need to focus on research that helps us identify areas of Medicaid spending that could provide the same or better outcome at lower cost. There are going to be upward pressures on Medicaid budgets due to the aging of the baby boom, new RX drugs, et cetera. So finding efficiencies is essential. And I think there's going to be certainly ongoing pressures to reduce federal spending that will continue as well. One area that has been suggested as promising for savings would be helping states reduce costs on their eligibility systems and updates to them, and in negotiating with outside vendors. Maybe CMS could catalyze state efforts in this area. I think we need more research that spotlights promising places that could save Medicaid resources without compromising outcomes or achieve greater impacts for a given investment. I could reel off some areas, but I think maybe leave that for the discussion. With a heavy reliance on Medicaid managed care, especially from publicly traded plans, I think we really need more research that helps states figure out how they can do more to hold capitated managed care plans accountable for delivering value for Medicaid dollars. Are there important differences in costs and outcomes across plans within a state and between nonprofit and for-profit plans? How can states more effectively negotiate with plans and exercise more leverage in these negotiations? Which states are more successful at that, and how are they doing it? There's some newly available resources, the CMS Managed Care Program Annual Report and the Mandatory Child Core Set that could be useful as sources for research here. Would also highlight enrollee input as an important area for more research. I think it's really important that we build on the important groundwork laid over the last several years, such as what Jamila described in her talk earlier in the series. I think we need more information on what types of decisions beneficiaries most want to weigh in on and how that aligns with the scope of current advisory committees. I think we're going to want to explore whether there's a business case to be made, whether implementation costs can be reduced by tapping enrollee input and guidance on key implementation decisions, for example. Then we need to understand what solutions states and programs have implemented that helped address barriers to appropriate compensation for enrollees for their time, and other mechanisms beyond advisory groups that CMS and states should be using to systematically get input, guidance, feedback from enrollees. As I flagged earlier, the state variation in per capita spending is an area I think crying out for more research. I think it could help us point the way to areas where states may be spending too little and too much on a given population group. The area, what effects do Medicaid spending and healthcare receipt have on other sectors is an area that I think really needs more attention, and vice versa. What impacts do investments and cutbacks on other sectors have on Medicaid? We need more research that moves Medicaid out of the silo, along the lines of what Chema described, that focused on SNAP and Medicaid together. We may think we're saving money when we cut back somewhere, but the cost may just be showing up somewhere else in the system or down the road. And lastly, given the very different waivers that were approved over the last 8 years, as a field, I think we're going to want to make sure that we're doing the research that's needed to speak to them and in order to guide future decisions on which to continue and extend to other states and which to discontinue. So with that, I'm going to turn the floor back to John. I'm going to stop sharing. There.
All right, thanks, Jenny. That's a great talk and a really nice agenda there. So, so people are encouraged to put in questions, but I've got a couple that I want to ask you. And I want to start with the big picture one. I think the cons here is this is impossible to answer, and the pros are you can sort of do a good job speculating. But let's sort of kind of step way back, and this is really about, you know, what can we expect to be accomplished, and what are the kind of the sort of the political economy inside the federal government. And so, you know, when I look at the incoming administration, there's at least kind of two factions. One is sort of the traditional kind of libertarian Republican type of approach that maybe is captured best by the Department of Government Efficiency, the Ramaswamy, Elon Musk approach, and they want to cut $2 trillion out of the federal government budget. Just as an exercise, I encourage everybody to try to go back and look at those slides you showed that show the percentage of spending on all these different programs and interest and Medicare and Medicaid. And those are percentages. The total government budget is about $6 trillion, and you'll see just how hard that $2 trillion is going to be to try to get to. But I think it's a helpful exercise. But so that's one wing that's sort of focused on cutting government spending. I think there's sort of an economic populist wing here that maybe RFK Jr. is in there. He's going to be the head of HHS. You've got Mehmet Oz, who's going to be the head of CMS. It's not clear what his priorities are, but he did sign on to a Medicare for All type of thing with Bernie Sanders, I think, going back a few years. And then I think if you look at Trump, you know, the health reform has not been a priority. I mean, you can sort of see what he talks about, and health reform doesn't come up there. In his first term, I think the first really big hit on his approval ratings came with the attempt to repeal the ACA. And that really, you know, didn't play out well for him. You know, a lot of the swing in people who voted for him are sort of, you know, working class, maybe people who are on Medicaid. And so there's sort of some dangers here in cutting Medicaid. So I think my questions here are maybe kind of two. One is, you know, where do you look for change to happen? So it might not be coming from President Trump, but, you know, are the Republican senators or Congress people who have, you know, kind of indicated that this is where they really want to go and where they really want to kind of make some movement, and they would have to lead this. I'm assuming that it wouldn't really come from somebody in the Trump administration. That's question number one. And question number two is, are there some of those possible changes that you put in there that are kind of easy to do, either through executive action or sort of an easy thing that kind of gets through Congress and the Senate, maybe that's sort of easy to let some things slide, and so you can kind of get rid of the 90% match or something like that, that doesn't require as much of a legislative lift as passing a new bill or repealing a bill or something, repealing a law. So two questions. Who's driving this? Maybe the three questions. What's your take on this overall political economy? Two, who's going to be driving this if health reform, if it's not coming out of the Trump administration? And three, what are the easy things they can do?
Okay, so really easy questions.
Yeah.
I don't think we really know who the day-to-day people leading CMS are going to be at this point, especially on the Medicaid front. So yes, we know who the top folks are likely to be. And to your point, neither one has deep history on Medicaid or strong positions on Medicaid. So I think it's really going to come down to who gets named to Dan Tsai's position and to some of the other key roles within CMS. And I haven't seen any specific names as yet proposed. But I think that's going to be tell us how active a role the administration is going to play in supporting any Hill efforts to fundamentally change Medicaid. So that's the first thing I would say. I think you've read the room correctly. President Trump was embittered by losing the ACA repeal and replacement battle. He has no interest in losing something, like that again. But some of the things that are being talked about might not have as much heat attached to them, or might happen quickly, and so there won't have been like if you think about repeal and replace, that went on for months and months and months, and maybe that could be the case here too, but I think that's another dimension here. Okay, who's driving it? I mean, clearly there's some voices on the Hill that I think are sympathetic and maybe supportive of Medicaid cuts. And John, I think one of the divides is, I think you have, this is like such an old-fashioned term, but I remember it from my youth, deficit hawks. Like we're not talking about our deficit right now, but these tax cuts are large, and that's going to be another drain. And we've been kind of living beyond our means for a long time, and we haven't had to pay the piper other than through maybe interest rates and some other things that are not as obvious. So that seems like a in the mix here, and I'm not sure how strongly some of the leaders on the Hill will insist that the tax cuts be paid for, a big chunk of them be paid for. I'm not sure. I'm not sure what would be easy. And I think major financing changes to Medicaid that would greatly reduce the dollars going to states. That feels like something that's going to get a lot of attention and discussion, especially if there's sort of across the board losses to states, that governors would have something to say about that, and that feels like it could change the dynamics, unless and some governors are supportive of a smaller federal government, even if it means kind of less federal dollars to support healthcare in their state.
Okay, great, thanks. Julie Donahue put in a question, and so here's her question. She says, thinking about research that may be particularly salient for some members of Congress, what are your predictions on the impact of draconian cuts to Medicaid on rural hospitals? Any pointers on research that would be helpful on that topic?
I think Julie just suggested a research topic that will be very salient to many legislators. I'm thinking of House members that have hospitals in their districts. I'm thinking governors, I'm thinking senators. I really think that issue is a powerful one. And it goes beyond the hospital, but certainly that stands in for all that we worry about in terms of rural healthcare, or much that we worry about. I've heard different kinds of things around cuts that could worsen our mental health crisis. That feels like you're on safe ground. If you're doing analysis that could be informative to research, to political leaders in that arena, since there seems like there's bipartisan support for dealing with the so-called the children's mental health crisis and mental health issues more broadly. I think the substance use issue cuts two ways. I think there's been, tremendous, there's been more support on the opioid front related to expansion. But I recently was in a conversation with someone saying that someone in the Medicaid ecosystem said something to the effect that maybe better to focus on Medicaid enrollees, quote unquote, who are playing by the rules, who are doing everything, quote unquote, the right way. So your hairdresser, the person working at Walmart or whatever the poster child is for that. But I think that gets into like the big picture questions around who is deserving and who is not.
Great. Okay, thank you. Here's one from Tim McBride. Given the variation in how expansion was done, some states by legislature and some by ballot initiative and some in Constitution, if the feds cut FMAP, has there been research or thought given to what would happen to various states?
Tim McBride, so nice to see or hear your name pop up. So my colleagues are doing that research right this minute, Tim. They're looking at if the FMAP drops and from the enhanced match, what would be the loss of federal dollars to each of the states that would be affected? And if that causes states to pull their Medicaid expansion, what would be the impact on coverage, out-of-pocket spending burdens, provider revenues, a whole host of different types of outcomes like that, state fiscal outcomes, so both people, providers, and states. They're working on that right now, and I think it'll be out early in January. Because as you would guess, the implications, it's important to have that information for each of the 40 states and DC. But also the picture does differ from state to state.
Okay, that's great. Well, this is wonderful. Unfortunately, we're at time here, Jenny. That went really quickly. So thank you so much, Jenny, for sharing your insights. As always, just really valuable, and love to hear them. I want to thank everybody for joining us today. You'll get a 2-question survey about the session, which will help us continue to make the program better. And we will see you again in 2025 when we restart our series. That's going to be on Wednesday, February 12th. And we're going to have Jacob Wallace from Yale talk. He's done some really great work on an area that should be of great interest to all of us, which is Medicaid managed care. He's got some of the leading papers here, and he's going to share some of his outcomes from a natural experiment comparing managed fee-for-service, managed care versus fee-for-service in one state, and possibly at least one state. Maybe he'll share some other results. He's got a lot of great data out there. So looking forward to that. I hope you don't miss it. Make sure to stop by and RSVP at the series website, Medicaid Insights Colloquium.com. Thank you, and have a great holiday season.